All right. So we are going to run through the way that we do echoes at the moment. Jane has put together a document that has pictures and outlines of all of the different views and why we're doing the different views and what the normal ranges are and what settings you should change and stuff. So this is going to be a pretty technical discussion later on once we're going through that part. Really echo acquiring images is difficult because they're tiny, tiny little movements, aren't they? Like everybody that's tried, you just kind of, it's so hard to get the right angle. And as soon as you get kind of used to it, and then you get chamber enlargement and everything's in a different place and a different angle and stuff. So it can be quite hard to comprehend where you are in the heart as well, looking in 2 dimensions when things are 3 dimensions and the right side curves around the left and it's all very sideways. So the first thing I want to point out is interpreting echoes is not your job necessarily. You've always got support in that. And as long as you can acquire the images that we're going to run through on this list, interpretation can be done either by me, and if I'm stumped, then it goes to a cardiologist. But technically, if we're getting these images, it should be an interpretable echo. The nice thing about echoes is there's actually pretty limited diseases that are present in the heart. So I just want to essentially go through a list and make you guys come up with a list. Let's talk about congenital heart disease in dogs. What is the most common, do you reckon?
PDA.
Good. Probably not the most common. Which one?
Aortic stenosis. Aortic stenosis.
Yeah.
Tricuspid dysplasia.
Good, yeah. Which breeds do we normally see that in?
Labradors.
Good. Excellent. So Labradors get their own special kind of tricuspid dysplasia, and it's actually really common amongst Labradors. And because a lot of right-sided murmurs are very low grade because they're low pressure, like it's not like these dogs have pulmonary hypertension and a big like regurgitant jet and a lot of noise. You often don't hear the murmur until quite late in the course of disease when the tricuspid, when the right atrium is quite dilated. But they get this anomaly called an Epstein anomaly, which I'm going to tell you about because if you see it, you never forget it again. But it's essentially when you're looking at a 4-chamber view of the heart, so you're looking at the heart side on, you're looking from your right parasternal 4-chamber, so you've got the right side of the heart closest to the probe, and you see the mitral valve in the bottom part, in the left side of the heart, and the tricuspid valve is actually apically displaced. So they don't sit next to each other when you're in that view. So the tricuspid valve is down here, and it's pulled right down into the kind of apex of the heart. And they've often got quite profound right atriomegaly associated with profound regurgitation. So that's the Labrador tricuspid dysplasia. It's quite distinct. Tricuspid dysplasia can be quite subtle though. So it can be just like one little clubby valve and you just see the regurgitation and go, oh, it's a young animal. It could be either degeneration or a congenital problem. What else?
PDA.
Good. Yeah. Did you say PDA?
PDA. Patent ductus arteriosus.
Yeah, oh,
PDA.
yes. I think somebody said that. Yeah. I've got that. Yeah. Sorry. Excellent.
VSD.
VSD. Excellent. Yeah. And another SD?
SD.
ASD.
Atrial septal defect.
Yeah. So realistically, we see that really rarely. And when we do see it, it's usually not clinically significant. There's not enough of a pressure differential between the 2 atria to make the blood shifting really significant, unless it's like a whole window missing of the atrial septum. That's pretty much it. That would be kind of, I mean, obviously there's like tetralogy of Fallot. Never seen it. Never want to see it.
Yeah.
And the reason why I always say to people with a young dog wanting an echo, is this an owner that's likely to pursue further treatment? So for example, if we've got pulmonic stenosis as the cause of the murmur, I want a cardiologist to have done that echo so that they're then comfortable recommending ballooning or not. Whereas if I do the echo, then a cardiologist then has to repeat it to make sure that they're comfortable doing an invasive interventional procedure. And we don't know what the congenital abnormality is going to be when we're calling up. A lot of these abnormalities are the same thing with a PDA, but like aortic stenosis, we usually don't treat. and a VSD and tricuspid dysplasia, there's not really any interventional stuff. So then it's worth us doing the echo. But I always do give people the option of going to a cardiologist first so that they can pursue further intervention if they want to. What about acquired heart disease in dogs?
Degenerative mitral valve disease.
Yeah, it's pretty much all of them. So this is by far the most common thing you're going to be seeing. So what sort of cardiac changes do we get with degenerative mitral valve disease?
Left atrial enlargement.
Excellent. What else?
Left ventricular enlargement.
I think, are you on mute, Jane?
Yes. Sorry, my family's very noisy. I'm just going to run downstairs and tell them.
Mine too.
I was very lucky, got delivered a tea.
Oh, that
is
is
that?
nice. That is very nice. I like your jacket.
Oh, well, thank you. Everybody here loves this jacket too.
It's actually, I wore it out to pizza on Saturday night.
So comfy.
It's
I love
warm.
it. Yeah.
So we've got left atrial enlargement. We've got left ventricular enlargement. Can you expand on that? Is that eccentric or concentric hypertrophy, Zane?
Concentric hypertrophy.
Excellent. And what causes that?
That's a good question.
You know the answer.
The increased force of contraction over time is going to cause hypertrophy of the left ventricular.
You're getting more technical than I was thinking. So what causes the increase in force of contraction?
I think Starling's law, like the heart wants to pump stronger to get more blood out because more blood's going backwards. That makes sense?
Yes. Yeah. So what drives, so Starling's law describes a phenomenon where the more stretched the heart gets, the stronger contraction is going to be. So when you stretch those myofibrils apart, the further they get stretched, the more strong contraction is going to be. So if we've got more stretch of the left ventricle, what's causing that? Why is the left ventricle getting more full than it normally would?
Volume overload.
Yes, exactly right.
RAS.
Yeah. So why do we get RAS? I've quizzed all of you on this before, but so one of the very early changes in heart disease is in degenerative mitral valve disease, I should say, is less blood's going out the aorta to the organs and kidneys specifically, and more blood's going backwards. So we just get this reduction in ejection fraction and an increase in regurgitant fraction. And we don't use those terms very often in veterinary medicine, but I think they're nice descriptors. Does everyone know what I mean by that? How much is going out versus how much is going backwards. So if you've got a reduction in ejection fraction, kidneys get less blood flow. What happens to the kidneys when they get less blood flow?
They freak out and try and retain more fluid.
Yes.
Or RAS.
Yeah.
They activate RAS. Yeah.
Yeah, exactly. So we get renin secretion, we get aldosterone secretion. Yeah, excellent. And we start to retain fluid. So these dogs are very volume overloaded. So that internal ventricular diameter is a reflection of volume overload. So where Zane said we get hypertrophy of the left ventricle, that internal diameter is a reflection of how much fluid they're retaining, which is a reflection of a reduction in ejection fraction and an increase in regurgitant fraction. It's going the wrong way. So what we should get if we've got more stretch of the heart during diastole and we've got, due to Starling's law, increase in contraction during systole, what's going to happen to our fractional shortening? Is it going to go down or up?
Up.
Up. Excellent. So we're going to get, oh my God, I've forgotten the word. Essentially increase in systolic function as a result, compensatory result of increase in volume. So the difference between diastole and systole is going to be more. Has anybody ever done an echo or seen a dog where they've still got the increase in their ventricular internal diameter and then at the end of systole is not, there's not that hyperdynamic, that's the word, hyperdynamic systole. There's not that hyperdynamic increase in systolic function. Has anyone seen that? Yeah. So that's a really end stage ventricle. That ventricle is like tanked all its ATP. It doesn't have any more energy. It's got fibrosis in the wall. It can't contract anymore. And the calcium cycling is not working anymore. So that's a dog that's about to die. With degenerative mitral valve disease. If it's DCM, that's a different process. But they look really similar. And so it can be actually quite hard to differentiate in really, really volume overloaded dogs who are really on the cusp.
Would you do a bit of pattern recognition at that stage? It's like, oh, it's a Doberman versus it's a Cavalier, or is that?
Yeah, absolutely. I'm doing that before I put the probe on. Yeah.
The other thing that I heard was that DCM dogs, generally the left ventricle and the left atrium are both enlarged to the same extent, whereas in end-stage mitral, the left atrium still looks a bit bigger than the left ventricle, even though they're both enlarged.
That's a really good tip. So what causes left atrial enlargement?
The regurgitant jet going back in.
Yeah, so increased volume in the left atrium.
Yeah.
And now, is it stretch or growth?
Both, maybe.
So mild increases in pressure will result in growth of the left atrium, and it actually grows to increase in size. It doesn't actually stretch to increase in size.
Mm-hmm.
Now, the reason that that's so significant is because you can have a dog with a 5 centimeter left atrium who's not in congestive failure because there's no increase in pressure in that left atrium. It's had time to grow and adjust, so it's compensated for the increase in volume in the left atrium. You can have a dog, same breed, same size dog, with a 2 centimeter left atrium who's had rupture of a cord and hasn't had time, chordae tendineae, hasn't had time to compensate for that increased volume in the left atrium. And the pressure in that atrium will go up really fast, and they will go into failure without having left atrial enlargement. So whilst left atrial enlargement is a really good indicator of presence of increased regurgitant fraction, it's not always that reliable because it depends on enough time for that left atrium to compensate and grow. Make sense? Mm-hmm. So it doesn't, we can get animals in heart failure if there's been an acute injury or something like that, which increases regurgitant fraction acutely. We will get animals with normal left atrial size. Good. Just to really make you nervous about interpreting your echo. Could still be heart failure.
But they should still have a really tall E wave, even though they're left atrium.
Exactly right. And this is one of the reasons why we've added those new values into our echoes, is because we can't necessarily rely on just chamber dimensions. We need to be measuring pressure differentials between the chambers to be able to diagnose heart failure. So I'm going to talk about the E and A wave when we go through looking at the images and stuff, and the significance of that. But let's just remember that big left atrium doesn't equal increased pressure in the left atrium. Just means that increased volume and pressure, different story. I get it. I like to have these captions on just in case people are listening, like on the bus or whatever, and don't have earphones. But gosh, they distract me sometimes. They're very, very unmedical. Okay, so that's all I want to say about degenerative mitral valve disease. What other acquired heart diseases in dogs?
DCM.
DCM, perfect. And we sort of talked about what we'll see with DCM. So volume overload of both the ventricle and atrium, fairly kind of relative volume overload. What would we expect clinically in a dog with DCM? What would the clinician have got us in for?
Maybe an arrhythmia.
Yeah, good.
Lethargy, exercise intolerance.
Good. Yep. What are the heart sounds like?
Low grade murmur. Sometimes.
Yep.
And
loud or soft?
Soft.
Pulse quality?
Weak.
Yeah, good. So they're the sort of things that when you're kind of about to do your echo, I do like everybody to have a listen and make your own impressions of what you think the heart sounds are like. Now, there's so much variation, particularly in large breed dogs. If they're obese, heart sound's going to be soft. You're not going to be able to sort of say, oh, it's probably DCM. Why is the murmur a soft murmur?
Because quite often the regurgitant jet or the leak in the valve is really wide. so the velocity is lower.
Yes, good. Yes. So is it the gap that determines velocity?
To some extent, yeah, I don't know. No, the pressure
No.
difference, I guess.
It's the pressure difference.
Yeah.
I still can't quite get my head around the width of the opening not being relevant,
Yeah.
but it's the pressure difference that dictates velocity. So that 4v squared has no like resistance in it in the way that we calculate pressure differences. Does everybody know what I mean by 4v squared? So that is the Bernoulli equation.
Okay.
This is where high school physics, it's the only time I've been grateful for having had to do physics as a prerequisite to vet. But cardiology has a lot of physics in it. So if you measure the velocity of flow from one chamber to the other, you can then calculate the pressure difference between those chambers by the equation 4 times the velocity squared. So if you've got like a tricuspid velocity of 3, for example, then you're going to square that. 3 by 3 is 9. Oh, maths is not my strong suit. By 4, 36 is the difference between the right ventricle and the right atrium. And then using mitral, if you've got a velocity of 6, I'm going to make somebody else do this. 6 times 6 is 36 times 4. Yeah, so I see a velocity of 6 and I'm like, they're probably pushing hypertension actually. So if that pressure difference is higher than 140, they've probably got systolic hypertension.
That makes sense because I've watched you do some echoes now where you will be like, this dog will have high blood pressure. You guys should do a blood pressure. And I'm like, how does she know? And that makes sense.
Yeah, so if you think about it, if you're measuring mitral velocity, mitral regurgitant velocity, we're measuring in systole, right? So which valves are open in systole?
Both
The
the
aortic or the pulmonic.
Yeah, exactly. So if we're just looking at the left side of the heart, aortic valve's wide open, ventricle's contracting. So there's actually an equilibrium to a mild pressure differential between the left ventricle and the aorta. So the blood's flowing towards the aorta, but they're pretty much at equilibrium pressure-wise. So if you've got the pressure in the ventricle being equivalent to the aortic pressure, which is our systolic blood pressure, and you're measuring the velocity between the mitral valve and between the left ventricle and left atrium across that mitral valve, you're getting a direct kind of calculation of systemic blood pressure. Does that make sense to everybody? I really needed a diagram when somebody explained this to me. Does anyone want me to try and operate?
I like your hand actions. That works.
They're so superfluous. They don't help at all. I catch myself going like this. I'm not sure they help, but thank you for the compliment. So if we can say that that's true of mitral regurgitation for aortic pressure, so mitral regurgitation velocity gives us an estimate of systemic blood pressure. What does tricuspid regurgitation give us an estimate of?
Pulmonary hypertension.
Yes, exactly. So systolic blood pressure in the pulmonary artery, which is an estimate of whether there's pulmonary hypertension or not. So high velocity tricuspid regurg equals pulmonary hypertension. High velocity mitral regurg equals systemic hypertension. I have led you astray solidly here. We're not on track. So DCM.
DCM.
Yes. What causes the murmur? And Jane said it's the gap. And she's right. What causes the murmur is the gap between the mitral valve. But it's because the heart is so stretched that the mitral annulus has stretched and the valves where they would meet are now not meeting. So the other thing that will impact the regurgitation is how much pressure the ventricle is generating. So what's happening to the ventricular pressure during systole in a DCM dog?
It's not increasing as much as it should.
Yeah, exactly, because contraction's incomplete, right? So we're not getting as much pressure generated which is why we get lethargy, exercise intolerance, because that ventricular pressure equates to systolic blood pressure, and they're just not getting that much blood flow out. They're all hypotensive. So if you've got decreased velocity in the ventricle, what's your mitral velocity going to do? Regurg velocity.
Decrease.
Decrease.
As well.
Yeah.
Yes. So it'll be low, which is going to make your murmur softer, because it's fast murmurs are loud. What else? Oh, we had an interesting case on Tuesday. I'm really going to lead you astray now. So I was thinking, Monday. I did an echo with Alex on Monday and confused her a lot.
Yeah, it really was confusing.
Yes. So the mitral regurg velocity was about, like, the pressure was about 80 when we calculated it. And it was a 10-year-old cavoodle with a degenerative mitral valve disease murmur, really profound left atriomegaly, left-sided ventricular volume overload. And the murmur was quite low grade. And they'd sort of said, well, we don't need to start pimobendan because the murmur's low grade, right? And so they finally sort of organized an echo, and this left atrium was absolutely huge, left ventricle's volume overloaded, but systolic function was still hyperdynamic. So we weren't in that phase of failure where we should have a drop in ventricular pressure due to loss of systolic function. And I was like, why is this velocity so low? And then we measured the E wave. Guess what it was?
2.
Yes, it was 2. I think it was like 1.98 or something. It's like as high as it gets. It was, the pressure in that left atrium was so high. So that mitral velocity, it equates to systolic blood pressure. But what it is estimating actually is the difference in pressure between the atrium and the ventricle. So you can either have a reduction in pressure in the ventricle and therefore hypotension, causing your soft murmur, slow regurg, or you can have normal pressure in the left ventricle but high pressure in the atrium, which is then causing resistance to the flow, the regurgitant fraction. So
it's kind of like the high pressure in the atrium is pushing the regurgitant jet back. It's like
exactly right.
Okay.
Yes, exactly right. So this is a dog in congestive failure because we've documented that the left atrium has increased pressure, and there's no valves between the pulmonary veins and the left atrium. Actually, maybe there is, but not good valves. They don't block the pressure from being transferred back up into the pulmonary veins and then causing pulmonary edema. So this is a really nice kind of estimate of that transition from stage B2 to C in degenerative mitral valve disease when we've got increased left atrial pressure.
Do you think the dog had a higher grade murmur earlier on that it just didn't come for a recheck at that point?
Yeah, and this is what the vet was saying is it came in. I checked it 12 months ago, and it's the same grade as it was then.
Oh, and we missed it.
I bet it went up, and now it's come back down again.
Yeah. Okay.
12 months is too long. So particularly, like, we know that degenerative mitral valve disease progresses within kind of 12 months from B2 to C, typically even on pimobendan. So if we're thinking off pimobendan, I'd be listening probably every 3 months, particularly in a high risk breed like a cavoodle.
Happy, yeah.
Okay, DCM.
I'm less confused.
Oh, good. I think we're going to go, because I keep going down little rabbit warrens, we're going to go through so much information. You're going to come out of this more confused for sure, but at least you'll be able to watch back.
And at least I'm less confused about that case that I've been.
Yes, that did, like, it wasn't until I was sort of doing the calculations afterwards. I was like, oh, light bulb, that's what it was.
I understand. So that makes sense.
Okay, so we covered degenerative mitral valve disease, and the principles are quite similar for tricuspid. We're just going to see the same thing on the right side of the heart. Yeah, right atriomegaly. It's pretty uncommon. What other things might you check if you were doing a clinical exam in a dog with tricuspid disease? So you've done your echo and you've gone and it's definitely got tricuspid disease. So we've got right atriomegaly.
Ascites.
Good. So I want you to put the probe on the abdomen. Check for free fluid. What else if there's no free fluid?
Like liver congestion.
Yes. Excellent. Good. So I want you to look at the cava and hepatic veins. Yep. Gallbladder wall edema. Good. Excellent. I find that's more common in acute right-sided congestive failure, so pericardial effusion and stuff. It's not as common with chronic. What else? Say you don't have the abdo probe with you for some reason. Don't do that. But, what else can you look at to document venous congestion and congestion? Like, because you might see right atriomegaly doesn't mean they're in stage C failure kind of thing, does it? Unless you're seeing venous congestion.
Chest radiographs.
Yeah. What would you see with right-sided congestive failure on chest rads?
Dilation of the pulmonary arteries.
Would we?
Sorry, the pulmonary. Sorry. Now I'm confused myself.
The pulmonary vein does get dilated with pulmonary hypertension. I don't know.
Pulmonary artery will be prominent with pulmonary hypertension. So if the mechanism of our right-sided congestive failure is pulmonary hypertension, and then right-sided failure, secondary to pulmonary hypertension, is called cor pulmonale. Don't look at the annotation. Cor pulmonale, so it's COR. Pulmonale, ALE is the end of the word. So right-sided congestive failure, secondary to hypertension, is called cor pulmonale. And then that right-sided congestive failure manifests as, what do we see? Ascites, congestion. What about on a chest rad?
Pleural effusion.
Can do. More common in cats than dogs, but yes, can do. What happens to the cava?
It's big.
Yeah. And you might see right-sided cardiomegaly, but Alex, can you comment on the accuracy of radiologist interpretation of right-sided cardiomegaly on radiographs?
Not very accurate. Unless it's like massive.
Yeah.
Massive.
It's got to be pretty big.
Yeah.
Yeah. And in those dogs, if you're seeing right-sided congestive failure, Jane, what does heartworm look like on echo?
Little squiggly heartworms.
Yeah.
The
See the heartworms. Whoa.
and the pulmonary valve.
Oh. Yeah. So I've never seen this. This is one of my bucket list career desires to echo a dog with heartworm, and Jane got to do it.
No way, that's so cool.
Look for worms if you're seeing right-sided congestive failure. Good. What about other acquired diseases, heart diseases? Are there any?
It depends if you pulmonary hypertension, I guess, if it's
acquired.
Yeah.
So we kind of talked about the changes that we'll see with that. High velocity tricuspid regurg, right atriomegaly if it's tipping into failure. Oh, that's the other thing I was getting at. I want you to check for jugular pulses in our right-sided dogs. It's a really easy thing to do. And I have to say, I'm really bad at checking hepatic venous congestion because I've got the echo probes on and it's hard to see and I forget often. And then I say, okay, I'm done. And then I go back and have a look at the dog's jugular and say, okay, no, it's fine. There's no venous congestion. But it is a nice thing to check. If the jugular is standing up without being held off, they're probably in failure. I think that's probably it for dogs.
Heart-based masses and pericardial fusions, things like that.
Yeah. So those are pretty obvious, I reckon. Heart-based masses, typically chemodectomas. So heart-based, when you sort of say heart-based mass, that describes chemodectoma. They have a really distinctive ultrasonographic appearance in that they're really round and really homogeneous. And you usually see them in your LAAO view because they're right at the root of the aorta. So they're right next door to that. So you've got the aorta and cross-section in that view, and it will be just kind of off the side like that. So when you're getting your LAAO view, you always fan up and down that kind of aorta. So you go post-valvular, valvular, and then subvalvular kind of space just to find your right location, and you will stumble across it in that view. What about hemangiosarcomas? Where do they live?
All right, atrium.
Yeah. So usually right auricle or right AV junction, and there's not many other cancers that grow there. What about, we had an intra-right atrial tumour that was bobbing around into the tricuspid valve and causing partial obstruction on Monday. Yeah. What would an intra-atrial mass be?
polyp. You get polyps, or like kind of just benign growths.
Benign growth, yeah. They don't behave very benignly. They're scary.
Hemangiosarcs as well.
Well, it could be, but actually inside the atrium is usually a myxoma.
Oh.
So that grow from the myxomatous tissue. I don't really know what that means, to be honest. But we actually went to surgery to remove one, put a dog on bypass. It was an 80-kilo dog. Got human perfusionists to bring their bypass machine in, and a human vascular surgeon. And we anesthetized this dog, and the mass just went into its tricuspid valve and blocked it completely on induction. Like any tone that the dog had would have like just dropped off completely. And we were like, oh, and the perfusionist was like, oh, that's fine, don't worry about that. And he climbs up on the table and he grabs the dog by the waist, shakes it up upside down, shakes the tumor back out of the valve, and then puts the dog down again. It was really remarkable to watch. The dog came back to life just fine.
Oh my God. I wonder how many people he's done that on. He's like, oh, I don't
I know.
Upside down.
Yeah. No worries. Anyway, we actually saw one on Monday. It's only the second one I've seen in my career. But yeah, usually myxomas. All right, I don't really want to talk about cat diseases, but I do want to just, because I don't want you guys to do cat echoes yet. Or in fact, I do want you to, but I don't expect you to, because they're just that little bit trickier. But I will just say that cats tend to get myocardial diseases, where dogs tend to get valvular diseases. So the presentations and changes that we see are very different, but the concepts are exactly the same. So if you've got evidence of congestive heart failure in a cat, or you've got a cat with respiratory distress and you're trying to differentiate respiratory versus cardiac causes, what changes might you be looking for if you're doing like a emergency echo on a cat?
Enlarged left atrium and thickened myocardium.
Yeah, exactly. And the thickened myocardium we look for because they are more prone to HCM. That's the most common cause of congestive failure. But we do see cats with DCM, cats with RCM, which like their heart looks actually completely normal when you're looking at it grossly. But if you're trying to differentiate causes of respiratory signs, that left atrium is the key. Exactly the same principles as with degenerative mitral valve disease in a dog. And the myocardial diseases that they get are really nicely set out in a review or a consensus statement by the ACVIN. And they've reclassified heart disease in cats to follow a similar kind of stage A, B1, B2, C, D, regardless of their heart disease. So they might say stage B2 with a restrictive cardiomyopathy, or stage B2 with HCM kind of thing. So that the way that we're trying to shift to looking at heart disease is, what is the risk of failure in this patient? And because that's what dictates how we're going to treat it. The diagnosis is not as important. Okay, excellent. So what I'm going to do is just share quickly. This is a document that I'll send around after this. So some of you will have seen that before. Hey?
It's very nice.
Isn't it pretty? I get great pleasure out of making pretty documents. Essentially, this is a summary of the list that we've got in our on our form that we do our echoes off. That it's just got a checklist of the views that I want you to get. We're going to go through that in more detail in the document that Jane's put together. But this is just a bit of a summary document. And the reason I sort of want to introduce it is because this has got the kind of conceptual views. And Alex, I think it might be handy as you're learning to echo to really have in your mind, you know how I was sort of saying you can either move the probe or you can tilt the probe. So if you sort of look here, your short axis view, the probe doesn't move. You're literally tilting rather than moving the probe right up through the heart there. And I think that kind of demonstrates that really nicely. So at this level, you're going through the ventricle down the bottom here. And at this top level, where you're looking at the aorta and the left atrium, you're going through the heart base. So you've tilted the probe up from the apex right up to the heart base. And you can sort of see that if there was, say, a myocardial mass or something weird that doesn't fall into our nice categories, in the process of moving between those views, you're going to see changes in the walls and things like that. And a lot of echo is first impression. So like that first 4-chamber view, I'm going, is contractility normal? Is there chamber enlargement? Are right and left similar in size? Is there evidence of like abnormal valves, brightness around valves and stuff like that that might indicate some inflammation in the endocardium, all that stuff. I'm just going to say again, Jane put this together and it's just such a handy document. I'm going to send this around as well.
I realise there is a mistake in there. So there's
there?
one thing I need to fix before you send it around.
Okay.
Just the EPSS measurement.
Which one?
The EPSS measurement.
Oh, yeah.
Like some of it I've written in there because like every time I looked up normals for things, I would find slight variations of things. So I'd put a few things in there, and there's, when you get to the EPSS, I'd put an alternative. It says less than, it says greater than rather than less than. I need to change.
Oh, okay, right.
Yeah.
Oh. I'm so impressed that's your only mistake.
There's probably others, so let me know.
Okay, we'll go through it. And I have been through this in a fair bit of detail. I use this document to generate the pretty one. So the first view I want you all to get when you're doing your echoes is a 4-chamber long axis right parasternal view. And what Jane's done is put together like kind of the order that we do the echo in. So all of the views that you want to do from the right parasternal long axis and then right parasternal short axis, etc. So we're talking about right parasternal long axis. Does everybody know what I mean by that? Yeah. So it's this nice one where in theory you've got all 4 chambers. In actuality, you've got a third of the right atrium. Right atrium is really difficult to assess from a right parasternal because it's just too close to the probe and we're looking from a triangular shaped beam, so we just cut it off. You can kind of move your probe a little bit more towards the heart base to try and optimize it, and you can zoom to try and optimize your focus on that area to try and improve your image. But if you can't get a long axis view accurately, width measurement accurately, just do it from the other side. Please take a video of this view, just the heart contracting, because as I said, that just gives me such a good first impression of what's going on in the heart if I'm interpreting, and I'm sure cardiologists feel the same. So first measurement we do after we've taken that video is a left atrial diameter in long axis. This should be measured just before the mitral valve opens, so right at the end of systole. So you've got to pause, roll back, see the heart contracting, opening, closing, and get it right before it opens again. And the measurement should be made across the maximal dimension of the atrium, but parallel with the annulus. Does everyone know what we mean by annulus? Yep, it's a bit of a strange word. While you're still in that long axis view, you can get the width of the left ventricle during diastole. This is a new measurement that we've just added to our form. And all it does really is just gives us a sanity check for our cross-sectional measurements. So when you're doing your M mode, you're obviously measuring the left ventricular internal diameter in diastole, but it's much easier to get a little bit oblique in a cross-sectional view when you don't have that kind of perspective of the 4 chambers, and you might end up underestimating, or it's pretty hard to overestimate that left ventricular internal diameter. Now the way we want you to do this is in your 4-chamber view, and you can see this sonographer has moved the heart a little bit to that side of the screen. Can you see that? So it's a little bit more on an angle than that view was. The reason they've done that is to make sure that their line is perpendicular to the walls and parallel with the valve. So find the position, move your heart around, move your probe position around until you can find a position where the line for your M mode is really parallel with that valve. Then we're going to do M mode, and we're going to measure the internal diameter of the left ventricle. Or you can do a whole M mode study on this if you want, but the only measurement that we're recording in our form at the moment is the internal diameter. Is there any other notes on that view, Jane?
No, they just sort of said that if for some reason you couldn't get nice perpendicular views on the short axis, that you can submit this part as your M mode.
Yeah.
But they sort of prefer you to do it from the other one, but you can use this one. It's where it got a bit confusing. There's a lot of sort of double measurements in this.
And when.
And then it does sort of say afterwards that you can, on some of them, you can just select, they don't want you to necessarily put them all in, that you can just select the best ones if you're doubling up.
Yeah, okay.
Sorry, Anna, just with that one.
Yeah.
Do you have like a tolerance amount for how much difference there would be between the two LVIDD measurements? So like if it's within 10% of each other, you're happy. If it's more than 10, we should double check them both, kind of thing.
Yeah. Yeah. So I think you get a pretty good impression of which one's more accurate based on your kind of alignment and stuff. But like we've all done a short axis M mode and gone like the papillary muscles are just a little bit skewy if I think I'm a little bit oblique, but I can't get a better angle on this. So if you're out by more than 10%, that would be my kind of margin of error that I would consider acceptable. Then I would probably make a note in my notable findings that M mode was mildly cross-sectional and the long axis internal diameter suggests ventricular volume overload, and therefore pimobendan is being recommended, even though my LVID in short axis wasn't didn't indicate that. Does that make sense?
Yep.
So 10%. That's like standard lab testing. If you can't replicate the same, like 10% is pretty much the margin of error for everything. Sorry. Nope. Next one, you're in exactly the same view. All you've done is moved your line slightly. So you were down through the ventricle here, and then you've moved the line slightly up. So you're catching the apical leaflet of the mitral valve as it meets the the interventricular septum during diastole. Now this is a measurement. If you've got profound left ventricular volume overload, what's going to happen to how close the mitral valve can get to the septum?
It's not going to get close.
Yes, exactly. Yep. So this measurement here, no, that's right, Jane, isn't it?
Yeah, no, see, I've written underneath another report what I read said greater than 7 millimeters, so it should say less than 7 millimeters. But I was looking last night, and like the Boone cardiology textbook just says less than 0.77 is normal, so we could just change it to 0.77 up the top and get rid of that. So instead of 8, change that to 0.77 and then get rid of that other sentence, and then that averages it out. Yeah.
Okay, beautiful.
Yeah.
Okay, done. Okay, so for this measurement, essentially you can't artificially get it too close, basically. So just take the measurement at the narrowest point. As Jane said here, can't be underestimated. The narrowest EPS S distance should be selected for measurement. And just don't use that first cardiac cycle for any of your M mode measurements. Next, and I have to say with my machine, I often don't do it in this order because I use the low frequency probe for all my color flow and velocity stuff, and the high frequency probe for all my like accurate sharp wall measurement stuff. But with the machine you'll be using, we're going to put color flow across the mitral valve. And I want to make a note here that the window has a little bit south of the valve as well as north of the valve. So for any valve, we need to be assessing how is the blood moving through during like atrial contraction or ventricular contraction through the aortic valve. So do we have turbulence arising in the subvalvular area? Do we have turbulence arising post-valvular? Or do we have regurgitation through that valve? And if you don't have the window on both sides, you could miss like a mitral stenosis, for example, which we didn't put on our congenital heart disease because it never happens. I'm sure it does, not to me. But yes, particularly important for pulmonic and aortic, where we see subvalvular disease, both regurgitation and increased velocity. So we see diastolic disease as well as systolic disease in those valves quite commonly. So very important to have your window covering both pre and post valvular areas. Now what's really important here, and I think it took me a long time to learn this just by fiddling with the buttons, but Jane's given us a really nice range. So PRF is the number that sits on your color flow scale here. So if you change scale, if you've got color flow on and you're like, oh, big mess, can't see any regurgitation, you want to get your PRF somewhere between 0.8 to 1.2 when you're looking for mitral. And the PRF that you use is going to differ according to what velocity you're looking for. So this is a really nice kind of cheat sheet to have with you if you're trying to remember what to use. I actually find, for me, my eyes, 0.7-ish, 0.73 is my favorite for mitral. Works best for me, but between 0.8 and 1.2 for mitral. And then you want to do the same on the tricuspid valve, and bearing in mind it's really close to the probe, and a lot of tricuspid regurgitations like literally just will hug the wall that you can't see on your 4-chamber view. So you don't rule out tricuspid regurgitation based on normal color flow in this 4-chamber view. The PRF that we're using for tricuspid is slightly lower. So bear in mind, if you're going straight from mitral to tricuspid, you're going to have to fiddle with your scale a little bit and get that number on your color flow scale looking better. Cool. And the other thing I'll say is high heart rates. It's so hard to see regurgitation. Pause, freeze it, scroll right back, and then work. And I say scroll right back to the beginning because it's much easier to comprehend what's going on if you're seeing it in forward motion rather than in backwards motion. Right. So, and then scroll forwards, give yourself some time to look and see if there's anything happening during systole. If systole is really fast, normally you can't see it as well. So next view we're going to go from the right parasternal 4-chamber view, and we're going to turn our probe very slightly anti-clockwise. So it's, if you've got a dog lying on its side, normally you'll have the probe underneath the dog and you'll have the light. If the spine is 12 o'clock, you'll have the light pointing at around about 10:30-ish for your 4-chamber view. And for your 5-chamber view, you're just going to like 9:30, 10. It's a really small movement. Does that make sense conceptually?
Yep.
Yeah. So the spine is 12 o'clock. You're starting at 10:30, 11. You're going to 9:30, 10:30. It's a very tiny movement. And that's going to allow you to capture that aortic valve and the ventricular outflow tract. So you can see mitral valve here. And then you can see aortic valve really nicely in cross-section across there. I can see from this view that the post-valvular aorta is not dilated, which makes aortic stenosis less likely. We often see in cats with that focal hypertrophy there a really big dilated post-valvular aorta, and that's just a really nice thing to note. Like I really want to look at the aortic outflow tract in this cat and whether maybe there's some systolic anterior motion. Then I want you to put color flow across there. And as I said, make sure you're capturing subvalvular area as well as post-valvular area, because most of the time with aortic stenosis in dogs, it's a subvalvular stenosis, and that turbulence starts below the valve. And there is often valvular damage associated with that turbulence going through the valve. So we get a regurg jet as well. And you won't see that if you're only looking in the post-valvular area. Now this is one that I'm consistently not doing. The M mode LAAO, I've tried a few times, and she's just so grossly underestimating the left atrial width in an M mode. So we're in our 5-chamber view. We've got our line directly across the aortic valve, and sitting right underneath that is the left atrium. Is anybody having better luck than me with this view?
I've been practicing doing it, but I haven't actually been taking the measurements because I haven't put the ECG on.
Yeah.
So I mean, it's listed in the reviews as what we're supposed to have, but then the cardiology sort of online stuff, the cardiologists were saying they think it's really unreliable in dogs.
Yeah.
But it's just in that thing that we're supposed to submit.
Yeah.
Yeah.
So what Jane's referring to is we're looking at having all our sonographers certified with this International Veterinary Ultrasound Society. What's the second S? RVUSS? Anyway, it's an international certification for like that. Essentially, you've been trained in ultrasound and you've got adequate skills. You've got to submit 20 reports, and it's quite a rigorous kind of process. But they dictate what views you need to get to put in your reports. So we are starting to practice this, but clinically, I agree with a cardiologist. I don't see an application for this in dogs. I think in cats, because sometimes the LAAO just doesn't line up in short axis, it's probably going to be helpful. But essentially you're lining up straight across the aortic valve into the left atrium, which you've cut short because you've got your 5-chamber view, so you're not actually optimizing your left atrial dimension there. And then you're going to do the M mode, and it has to be where at the beginning of the QRS cycle. So right at the beginning of systole?
Yeah.
Oh, so electrical systole happens before physical systole. So it's probably, so it must be right after the left atrium's contracted. So when it's at its smallest.
Yeah, the ratios are different. So it's 1.3 instead of 1.6 for the cutoff.
Yeah.
Yeah.
I might make a note of that.
It does say it in very small fine print somewhere, I think. Oh, no, you can't read it.
It is up there. It is there. Sorry.
We can't see it.
Yeah. Excellent. So yes, let's keep practicing that one, and then one day we'll get a case where like that helped us clinically. So now we've gone from 9:30 to 10:30 on our dog. This is the spine. This is the probe. We're going to go to 9 o'clock. So we're pretty much gone. In fact, it's probably close at 8 o'clock. We're pretty much gone a full 90 degrees from where we started. So we were looking at the heart in long axis. And if you think about it, I want to get it in perfect cross section. I have to be 90 degrees from where I started. Yeah. So this is called the right parasternal short axis view. And if you're struggling with that concept, this is probably a better thing to look at than this. Sorry. So you can see that the like the fan of the probe is going through the base of the apex of the heart, the tip of the ventricle, and then you're going to fan up towards the base of the heart. And if you think about where the heart sits in that chest, you're fanning on kind of a diagonal. So you're kind of going towards like 10:30, 11 o'clock on the heart clock. Okay, so first thing we're going to look at is the left ventricle. We want to have a look at how chunky the papillary muscles are, whether there's like no lumen, which we see sometimes with dehydrated dogs, whether there's a huge lumen, which we see with volume overloaded dogs. We want to look at the wall thickness. Is it nice and symmetrical right around? Is it a round shape? What might cause flattening of the interventricular septum?
Increased right ventricular pressure.
Excellent. Good. What might cause increased right ventricular pressure?
Pulmonary hypertension.
Excellent. Or congenital disease. Yes, excellent. So pressure overload in the right ventricle is going to be caused by stenosis or increased afterload. So they're the two differentials. So M mode there's so many measurements in the end mode. It's really important that you've got as circular as you can get and that you're not on an oblique, because you can imagine if you're looking through this section kind of a little bit sideways, you're going to underestimate the left ventricular diameter. What we're measuring here is the interventricular septum, left ventricular internal diameter and free wall, and the difference between diastole and systole. So this is giving us information both on our diastolic volume, so DCM and other volume overload diseases are going to be diagnosed based on this, and as are the other diseases. So pressure overload diseases will cause what change in the heart?
Dilation of the chamber of the ventricle.
Pressure overload. So aortic stenosis,
sorry,
what would you expect on this?
Thickening of the free wall. Yeah.
Good. Yeah, excellent. So we're going to get concentric hypertrophy. So what that means is where the ventricle wall started here, it gets thickened on all sides. So the lumen actually gets more narrow and the wall gets thicker to measure. Whereas eccentric hypertrophy is growth around increased volume. So it grows on the outside of the muscle wall. So it does all the maths for you, essentially. We've got an automatic conversion and normalization according to weight using that Cornell equation. So we need to submit our form and have it look at it in the Excel spreadsheet to know what the normal ranges are and whether they're fallen outside. And fortunately, all of the coding that Nicole George has done, full credit to her, they show up as different colors if they're outside of normal range, which makes it really easy. The left ventricular end mode of the mitral valve, again, this is not something I put in our list of images to get for us, but you may need to get it for your reports. Jane, do you want to expand on this one?
I think it's essentially just exactly the same as the long axis one. It's just they had it written in the options as sort of as a double check, really.
Yeah. Okay.
So it's still sort of calculating that EPSS. You can do that from this view rather than your long axis view.
Got it. Okay.
And I think there's some cardiologists that sort of like the short axis M modes, and there's some that seem to like the long axis ones. So, yeah, it seems like the IV USS seem to like the long axis, and having these short axis ones as backup. Oh no, they like the short axis, but the EPSS, they actually recommended that on the long axis.
I find that much more accurate because you can see the valve leaflet so nicely in long axis, whereas this you're just catching, you're not sure at what point you're catching it, you're not sure where your line is, kind of thing.
One thing I did notice when they have examples of good case reports on that website, and the case reports that they've got there for the echoes, a lot of people have done the short axis with the sort of fish mouth view to show that the valve looked normal. So to get a few of those in there as well.
Yeah. Okay.
But that
start taking pictures of that. Yeah. So it's not actually something that we need to kind of report on and put a number to, but it's nice to document.
Yeah.
Okay. Good. We can start taking pictures of that. Okay. So we're going to now fan up. So we've been moving up through the ventricle, up through the mitral valve, and then just high of the mitral valve, we're going to stumble across the this structure here called the aorta. Sorry. And we're going to see a beautiful peace sign where the three valves are meeting up. In theory, in reality, it's actually really hard to get it really round, isn't it? Does anybody struggle with that? Yeah. So, and I'm always saying anti-clockwise, clockwise, anti-clockwise, clockwise when I'm teaching people to do this. So it's the tiniest little movements, but essentially you've got the aorta in the middle. If you've got a little bit of like a bulge on the right side of your screen, you're too far clockwise. If you've got a little bulge on the left side of your screen, you're too far anti-clockwise. So it just helps you to kind of orient yourself, and the orientation will change slightly depending on chamber enlargement and stuff. So you just have to move in that kind of little 5-degree plane until you get it nice and round. And then often the left atrium is not optimized when you get your aorta optimized, which is super annoying. And the one, I think, pitfall that we see often is that the pulmonary vein will be dumping into the left atrium right here where I want to make my measurement. So you end up kind of overestimating left atrial dimension because technically the wall doesn't stop until there, but actually that's the pulmonary vein dumping into the left atrium, which might be a little bit distended because they've got a bit of congestive heart failure. So it's really important that you watch live where is your left atrial margin, and make sure that you're measuring to the left atrial margin and not overestimating that, because that will dictate whether we're putting a dog on pulmonary vein. It's quite a big clinical consequence getting that wrong. But this is why we do the long axis left atrial view as well, just to cross check, because we're making clinical decisions based on this measurement. So if I see a left atrial measurement that's like virtually the same as the right atrium in long axis, and then we've reported a left atrial enlargement on this view, then I'm going to say, oh, maybe they're a borderline B1 rather than a solid B2. So just looking at it all in context. End mode again. Sorry.
Yeah. That's the same as the annoying view on the other side, but it's the short axis view of that.
Yeah. So I've not once been able to get this lined up. Can you see where their line is through here? And the body of the left atrium is over here.
Yeah.
So I can't see how that would be helpful unless, and when the settings where I think clinically it would be helpful is if you like feel like you're not getting an accurate measurement, like your LAAO is normal and you're looking at the left atrium going, no, it's not, it's huge. So this is actually the left auricle, this part of the left atrium. So because we've got a lower ratio here, maybe that left auricular distension describes that left atrial enlargement. But yeah, it's a good one to practice, but not one that we're using a lot clinically at the moment. So then you're still in your beautiful peace sign aorta. You've got that nice and round, and you can see the pulmonary valve, pulmonic valve sitting right alongside it. They're right next door to each other. So then we're going to put color flow on the pulmonic valve. And again, we need to make sure we're getting subvalvular and postvalvular as well as valve. So you're going to change the size of your box to be a long sausage and sit over your pulmonic valve. And we're going to get a couple of different measurements from this position. We're going to get a PW below and above the pulmonic valve. Why do we need, so the one that's above the pulmonic valve, so subvalvular, we'll call that the RVOT, which is new in our form as of yesterday. Right ventricular outflow tract, so the subvalvular velocity. Why would we need to record subvalvular and postvalvular velocities differently? Isn't it the same blood going the same pace?
It can help you work out if there's stenosis there. So if you've got a difference in pressure over the valve.
Excellent. Good. And then you're going to put it in the postvalvular space. And if you've got stenosis across the valve, your postvalvular velocity will be higher than your subvalvular velocity. Cool.
Yeah.
And then you're going to get an average velocity. So what is CW, Alex? Have you read yet? Not yet.
I haven't read it yet.
No, okay. That was your homework for Monday.
Yeah.
So PW allows you to put the window where you want to measure. So you can be quite specific along the line where you want, what velocity you want to measure. Whereas CW measures just all of the flow along that line.
Oh,
so
makes sense. PW has the two little lines that you can move.
That's the window, exactly. Yeah.
Okay, cool.
So we're going to get a pre-valvular and a post-valvular, and that's what we're going to record in our forms. But we're going to do a CW just to get an overview of the velocity. Again, look at your PRF. You're looking at low velocity flow. So it wants your PRF quite low. So the CW essentially averages out your flow.
Yep.
So this is an excellent summary of interpretation. So if we're measuring less than 1.7 meters per second, it's normal. If it's over 4.5, it's severe, and then everywhere in between kind of doesn't matter because they don't treat it anyway if it's less than severe. It's still significant, obviously, and we should note that growing animals, the velocity can change, and it's worth rechecking for ventricular like remodeling and stuff like that. But yes, as Jane's mentioned here, some dogs will be greater than 4.5 and be completely clinically normal lifelong.
Wow.
Next view is actually sub xiphoid or xiphoid?
I say xiphoid, but I don't know. I could be wrong.
I think that too.
I say a lot of things wrong, so.
Me too. I've learnt so much from books and not from humans. So has everybody done this view? It's awful to do. You have to push so hard.
When I'm doing abdomens, I sometimes
see the heart. Yeah. You have to push so hard, but it is really nice to do because the aorta is lined up absolutely perfectly away from your probe. And there's no other view that we get. So if you think about the difference between PW and CW, if you're measuring CW, it's going to be measuring all the flow along the line from the tip of your probe right down to the depth of your screen. So if you're going across the ventricle, across like the right side of the heart to get to the aorta, you're going to be picking up things that are going to even out or change the velocity of flow if you're using CW. With this view, the only velocity that's kind of contributing to it is the aortic velocity because it's so nicely lined up.
Okay.
And again, you can get a really nice left ventricular outflow tract and post-valvular velocity and really nail your diagnosis of aortic stenosis.
I imagine that view is quite limited when it comes to deep-chested dogs, so like Dobermans where the heart might not be touching the diaphragm and you get lung in the way.
You can pretty much always get it.
You can,
but like it's brutal. Like it's so intense to dig that deep, and the dogs have to be compliant, and often they aren't.
Yeah, well, they're often not as heavily sedated for echoes.
Well, yeah, you can't. It's going to impact your velocity. So if we give Alfax, our systolic function is going to reduce, and our aortic velocity is going to go down. Yep. So it can be difficult. So we're going to get a CW across the left ventricular outflow tract and aortic root, and that's going to be like our peak velocity essentially, or our like AOPV essentially. It doesn't actually say to do your PWs on this view.
No, it just once those most of them from the other side, and then it sort of said, I think this one was listed as if indicated to do that one. So if you get nice views on your other side, then you don't need to worry about that.
Okay.
But maybe if you've got an aortic stenosis, you do.
Sorry.
Yeah.
So and I guess that highlights the point that PW, when you can select the window of velocity that you're using, it doesn't matter if you're going across another chamber to get to it. Whereas if you need a CW measurement, then it needs to be xiphoid. So then we're gonna flip the dog and the mat and the chaos, and we're gonna go to our left parasternal 4-chamber view. This is like such a nice image. Does anybody's images look like this routinely?
Never.
The key to this is, like on the other side, you feel for the PMI, the point of maximal intensity, and you put the probe there. This view, you feel for the point of maximal intensity and go really far south. Like I want you looking at the liver and then moving forward from the liver. because you want to be looking, if you think about where the heart sits in the chest on a radiograph, you want to be looking from right down at the base of the ribs, like at the xiphoid sort of area, to be looking from the apex of the heart up through it. And if you think about the angle that your probe is going to need to be on to be looking up through the heart like that, you're not going to be able to be perpendicular to the chest, are you? Because you're going to get cross-sectional views if you're perpendicular. You've got to be end on, looking at the heart, up through the heart. So it's a really awkward one to get. So if you're getting your heart looking a bit sideways, it's because your probe is on the side of the ventricle rather than at the apex of the ventricle, and you need to move further back.
Okay.
It just never looks this good. Don't wait for this image to pop up. But do try and get it as much as you can. And remember that the angle is the key to getting that, because there's no way you're going to get it from side on. So from this view, we want to measure blood flowing from the left atrium into the left ventricle, because we're a beautiful alignment for that. So this is where we were talking about the E and the A wave. Can you remember that case that had increased velocity E wave? Why was that? What causes increased E wave velocity?
High left atrial pressures.
Yes, exactly. So this is a view that we really need to get to differentiate dogs that are in stage B2 to being on the cusp of being in stage C. Does everybody understand the phases of diastole? Do we want to cover that? Does anybody need to rush off?
I think in terms of basics, I understand, but I don't know how much detail. I do start consulting, but in 15 minutes, so I've still got 15.
Yeah, I have to be off the phone by 10 as well, but we are actually nearly through this list of views.
So I'm fine otherwise. So I know the basics, but I don't know how much detail you expect us to know for that.
Yeah. So essentially, there's just two phases of filling. So the heart empties, systole, all the valves close. This is isovolumetric relaxation time. So the heart actually relaxes and dilates before any of the valves open. So it forms a little vacuum in the left ventricle, and then it sucks the mitral valve open. And I have to make the noise when I'm thinking about this to suck the mitral valve open. And it sucks the blood from the atrium into the ventricle, because the pressure differential now is actually negative in the ventricle and positive in the atrium. So the atrium is really full, right? Does that make sense? Yep. So that blood that gets sucked into the ventricle is completely passive. There's no atrial contraction going on. And that's the early filling phase. And 90% of the blood that flows from atria to ventricle occurs during that early filling phase. So that's our E wave, E for early. So that is the amount of blood flowing is going to depend on the heart relaxing properly. So if we've got like a restrictive cardiomyopathy or something like that, or if we've got pericardial effusion that's restricting that, we're not going to form as much of a vacuum, and the pressure differential between atria and ventricle is not going to be as good. Likewise, if we've got, or inversely, if we've got a bigger pressure differential, so if we've got like negative pressure in the ventricle and we've got a pressure overloaded left atrium, that is going to cause more flow at higher velocity from atria to ventricle. Make sense? Yep. The A wave is not as important in dogs, but we use the EA ratio in cats to help us understand how their myocardium is relaxing. So to measure whether they've got relaxation abnormality or diastolic dysfunction. I'm not going to go through that in detail now because it's too complicated and I can't remember it. But I have to look at
it's a time pressure, Anna.
Yeah, we'll call it that. It's not something that I want you guys to be doing at this point. And realistically, in cats, their E and A waves are almost always on top of each other because their heart rates are too fast. So it's not a good measure of diastolic function anyway in cats, in high heart rate animals. The one thing I will mention is that older dogs often have inversion of their E and A waves. So that's something that we'll see in several dogs, and we have sort of seen. So now that we're starting to measure this, you might see E being lower and the ratio actually being low. And that's a variant of normal in older dogs. I think it's just owing to fibrosis of the myocardium, like altered relaxation, but it doesn't actually have any hemodynamic consequences, so we don't worry about it. James written some really nice notes about cats, so you can look that up. Next view, we're going to reassess our mitral valve, but from the other side. And if you get in this view, you've got a really nice alignment to measure your mitral valve velocity. And I want you to record the highest velocity in our report. So you're going to measure it from the left side and the right side. And I want you to measure the highest one, because you can't overestimate it, but you can underestimate it if you don't have your lines lined up. Then we're going to look for tricuspid and look at this beautiful right atrium. You can see the whole thing. So all of those little cheeky jets that go out towards this wall, we're going to be able to see them when we put our color flow on and adjust our PRF to that range. And then our line is going to line up beautifully, and we'll be able to measure them and diagnose our pulmonary hypertension. From this view, you're still on a really awkward angle. Like, I want you to think I should be really uncomfortable taking this view. We're going to rotate very slightly to catch that left ventricular outflow tract, aortic valve, and aorta. And we're going to, let's say this is the 5-chamber view from the left parasternal.
So wait, are we rotating clockwise or anti-clockwise? Because this is when the dog's head's the other way, right? So you'd be going anti-clockwise.
I think it's anti-clockwise, but I can't actually picture it.
The dog's
anyone
head
else
being
picture it?
the
I think it's still anti.
It's still anti, yeah.
other-
I feel like I say turn anti-clockwise more often than clockwise, so I'm going to go with that. But if it doesn't work one way, just go the other.
Yeah.
So we're going to measure the velocity in the left ventricular outflow tract. So that's going to be just above that valve. We're going to measure, and are we going to use PW or CW for this?
PW.
PW, perfect. Yeah, PW above the valve or subvalvular, PW postvalvular, and we're going to get a CW Doppler of the maximum velocity. So if you look now, this heart's not on its head anymore. It's slightly fallen over. So we've moved our probe cranially to be more alongside the heart rather than at the apex. So you're going to be on less of an angle. Your light should always be towards the nose. What do you mean crystals towards the spine?
Well, these were the directions that I think was in one of my cardiology notes, but I think you do it slightly different. When I was doing it with you the other day, your views were nicer, but I'm on more of an angle. Like, I'm kind of, if you follow these directions, you're really sort of going backwards up the heart, if that makes sense. You're slightly more still keeping the original direction. So it's a bit different. So I just had to put that on there because I don't usually have you with me when I'm trying to do it at work. So I needed some directions, but
yeah.
I don't know if you want to think about that and see if you want to change it to how you do it.
So looking at this view, I am probably a couple of rib spaces cranial from where they are. So my heart's not on its head at all anymore. My heart's on its side. So I'm more level actually with the base of the heart. The aorta here in the view that I get is running a lot more perpendicular to the probe, and you get a really nice good quality view of the aorta here, but I feel like it's not superior to the one that we got on the other side as far as assessing the aorta. Where I think this view is really nice is that the other side, there's often lung getting in the way of your assessment of your pulmonic valve. And the pulmonic valve is so close to the probe up here, you can get really nice kind of isolation of the pulmonic regurg if you've got any. So this view where we're optimizing for our aorta, I really only get that view as a reference point to then tilt towards the spine, towards the heart base. to catch the pulmonic valve, which is wrapping around. Oh no, this is tricuspid, sorry. Oh, good picture. That's a great reference. Oh, I have no idea how they got that view.
It's just the opposite of what you're doing to get the pulmonic.
Oh, okay. I'm tilting dorsally.
You're dropping the tail of the probe or lifting the tail of the probe to flip between the pulmonic artery and then the view with the right atrium, if that makes sense.
Yeah. Mm-hmm. Yeah, it does. So this is, I still think that measuring the tricuspid velocities and things is going to be more accurate in your 4-chamber view, the apical view. But if you can see a jet but can't measure it, this would be a nice view to do. And I'm going to start practicing doing this one. It's not one that I do routinely. So again, we're going to do color flow on there, and then PW of the tricuspid inflow. So looking at whether there's alterations in pressure in the right atrium and right ventricle, and any tricuspid stenosis. So yes, then we're going to tilt the probe dorsally. So lift the tail of the probe as opposed to dropping the tail of the probe from the aorta, and that aorta is our reference point. We're going to go dorsally, and we're going to actually catch that pulmonic valve really nice and close to the base of the heart, to the probe. So if you're measuring a regurgitation, you can see sort of how nicely lined up that would be. So your line's coming down from your probe here, and it's just going to be beautifully lined up. Likewise, if you're measuring pulmonic stenosis and increases in velocity, it's going to be across, it's going to be really nicely lined up here. So again, we're going to do PW pre and post, and then we're going to do a CW across the valve.
And that next view, I didn't understand.
I've no idea.
I've never really done that one before. Yeah.
Oh my word. All right.
Yeah.
I think we're probably going to put a big line across here and say too hard.
Sounds good.
So there is a lot more information in here as far as like shapes of the waves and things like that. That's really important for interpretation, but I really want to focus on image acquisition and understanding the kind of basics of heart, particularly for our newbies, the basics of heart diseases and what the different manifestations look like. If you're able to get all of these views, we can diagnose absolutely everything. So you can sort of feel supported and then start to focus on interpretation and stuff yourself. As you sort of see those reports, what the interpretations and stuff are, you'll learn from that. It's probably the best way to learn. And books are good too. All right, I'm going to stop sharing my screen. Again, thank you so much, Jane, for putting that document together. I just found that so helpful. Awesome. Yeah, really good. So I've made that modification. Are you happy for me to send that around?
Yeah.
Now for everyone?
Yeah.
Great. Okay, super. And I'll send around the pretty checklist too, but Jane's is much more helpful. All right, I probably should wrap up. Any questions? Oh. All right, back to work, everybody.
Thank you very much for this. That was fantastic.
No worries. I hope it was helpful.
Thanks, everyone.
Bye, guys.
Thank you.
Bye.
See you.
Bye.
Bye.